There are more acronyms. Mike Hodges will speak on behalf of Amplyx, and it's on APX001. Another broad spectrum novel mechanism, completely new mechanism of action. And Mike, please share the plans. That's
Guten Morgen, Abend, meine Freunde and colleagues, Professor Connolly. I'm going to speak English or American English. These are my disclosures here, and hopefully this works. I'm the Chief Medical Officer of I'm the Chief Medical Officer of Amplyx Pharmaceuticals. I've had the pleasure of working with Professor Connolly for about 20 years. I repeat, the pleasure. So he'll be buying me Kolsch beers tonight for my compliments to him. We work together on both voriconazole and anitulafungin, and most recently on this compound here. Oliver, did you work on fluconazole as well? I can't remember.
not really.
No, it's all a bit of a blur for me as well. I don't have to tell this group here the serious nature of fungal infections and the unmet medical needs, and the needs for new compounds to help you treat these patients with serious fungal infections. We've already heard from one very promising compound from my colleague, the Synexus Candin compound, and this compound is a novel mechanism of action. This slide is courtesy of Janelle Netz. She presented this at the ID week, and on the right-hand side of the slide, you see all the good reasons why we need new drugs to treat the invasive fungal infections. This is a slide courtesy of a recent publication by John Perfect from Duke University in North Carolina. Here he lists all the mode of action drugs that are currently in development. And you'll see that there are 3 classic drugs that target either the cell wall or the plasma membrane, the outer side of the fungi. You have the polyenes, which punch holes into membranes, all membranes, including your kidneys. You have the azoles, which affect a key step in the synthesis of the plasma membrane, again disrupting the cell wall. And you have the beta-D-glucan inhibitors, and the most recent one you heard in the last talk. What we have here, though, is a special novel mechanism of action, APX001, which again affects part of the cell wall of the fungi, and that's described on the mode of action slide here. APX001 affects the GPI-anchored nanoproteins, and these nanoproteins translocate from the cell cytosol to the cell surface and form rigid structures, help the rigid structure of the cell wall. The nanoproteins also do other nefarious actions of the fungi, including biofilm formation. So inhibition of these GPI nanoproteins, which live in the wall, have pleiotropic effects on the fungi. This is some data that was shown at ID week last week, and what it shows at the top is various stainings, and in the graphs you'll see that there are the lengths of the Candida albicans. The staining here in green is a cytox green stain, which is a surrogate for cell death. So on the left-hand side of the slide, you see normal-shaped Candida albicans, and after 2 hours, you'll see changes in the pleomorphism of the fungi until they're elongated and are essentially dead. So our compound is able to kill Candida albicans, and again it's shown on the next slide that it has additional effects on alterations of the cell wall, including deposition or buildup of chitin, depletion of the mannin, because that's the target, the nanoproteins, and then you see elongation and essentially very, very sick fungal cells on the right-hand side. So we have this for Candida and we're hoping to repeat this for some of the molds as well. I'm going to tell you about summarize the activity now for yeasts and molds. As I said, our compound's a broad spectrum agent. It has activity against a variety of yeasts, including many species of Candida, as well as Cryptococcus. It also has activity against all the species that we tested for Aspergillus, including the rare molds, Scedosporium, Fusarium, and fungi from the Mucorales order, such as Rhizobus. It also has activity against Coccidioidomycosis and Cryptococcus neoformans. We've demonstrated synergy both in vitro and in vivo with the candins as well as the azoles. We have a long post-antibiotic or post-antifungal effect, and we have inhibition of biofilms. We also have done some preliminary resistance work, and the rate of spontaneous mutations is similar to the candin that we were testing. So it's looking pretty good so far, at least in the test tube and in the animal. I'm going to show you one of the in vivo experiments that we've done. We've done a bunch of these in vivo experiments across the yeast and the molds, including the hard-to-treat rare molds, either using 5-fluorouracil or cyclophosphamide as the immunocompromising agent. We've also measured survival and also measured tissue burden, and we've done some PK/PD work where the driver, it's not unsuspectingly for a fungi, is AUC over MIC. And we are looking to get about double-digit targets for AUC for clinical efficacy. So this is one of the examples that we're going to tell you, I'm going to show you. I'm going to show you the efficacy with regards to Candida auris. This is the so-called fungal superbug, and I think both at ID Week and also at the very good TIM meeting that some of us have just come back from in Belgrade, I think we're seeing some of the rationale why certain people within our community think that this has the potential to be a superbug. This bug is often multi-drug resistant. Also different for Candida, it's able to be transmitted between patients, particularly those in high dependency units, and that's not typical of your Candida that causes Candidemia. So this is new. Also, we've heard from Silky Slents from the Brompton Hospital, as well as the Tom Chiller in the US. Between them, they have 4 cases that developed rapid echinocandin resistance on treatment. So they had a fully sensitive bug to begin with, were treated with echinocandin, and they developed echinocandin resistance whilst on treatment. It's also very difficult to eradicate from hospital settings. You actually need to adopt the same disinfection policy that you use for Clostridium difficile. So it's very difficult to get rid of. One open question is, does it have a higher mortality compared to sort of ordinary Candidemia? And I think the jury's out there. There's certainly a high mortality associated with it, but it's difficult to untangle whether it's due to delayed treatment with the appropriate antifungal because of the background resistance, or whether there really is increased virulence of the bug. So this is some of our data, and I'll try pointing again. In the top, we have the various antifungal agents, and then we have the definition of what we're calling the MIC, and then we have the range on the left-hand side, and then the data for MIC50 and MIC90 going across. I think you'll be able to see that the APX001A, that's the active moiety, has the lowest MICs out of all the drugs that were tested. So we are obviously very encouraged by that, but as we always do within infectious disease animal models, the activity within the test tube is only half the story. And now we're going to move to the animal model that we conducted. Again, this was presented at ID Week by Mahmoud Ghanum's group, Dr. Larkin. And this is a survival model with the positive control being an insular fungin. The top 3 curves show almost 100% and 80% survival for 3 doses of APX001. Here we're using the prodrug. A lower survival for anular fungal and the negative control, 100% mortality by day 5. So that's good. So now let's look at the tissue burden that's shown on the next slide. And here's the tissue burden for kidney, lung, and brain. Again, on the left-hand side are the APX groups, with the anular fungin being in green and the negative control vehicle in orange. So APX has a favourable outcome, lower fungal burden reduction, or sorry, a higher reduction than anular fungin. But what's most interesting is the brain decrease. Here we have a significant reduction over the positive control anular fungin. And indeed, what we're finding across other animal models, Cryptococcus neoformans, a rhizopus model that was published at ID Week, as well as coccidioidomycosis, we're seeing good activity, good knockdown of fungal burden in the brain. In parallel to that, we know from related studies in rat and in human primates that our drug gets into the brain in good concentrations. So we believe that our drug is getting into the tissues of the brain and has great potential for the treatment of invasive fungal infections of the brain. So that's the animal model data. So would the data from humans, our first human trials, reciprocate the very encouraging data that I've shown you here? And we think it does. We've conducted 2 studies, both IV and oral, and we've measured the safety and the PK in both of those studies. And these are the studies as shown here. Study 101 was the IV study, and 102 was the oral study. Both of these studies are SAD-MAD, that's single ascending dose, multiple ascending dose. We also looked at oral bioavailability. We also looked at fed food effects. And we also looked at drug-drug interactions across these 2 studies. The third study here is a study we're just about to kick off with Professor Cornely and his colleagues here in Cologne. This is a study where we check that the PK and check that the safety is similar in a representative patient population. Rather like we saw with the Synexus compound, you need to make sure that what you see in healthy volunteers is going to be reciprocated in the patients. This is the design of the first study we did, the IV study. There you have the design of the single ascending dose cohorts, and then you have the multiple ascending dose cohorts, and last you have the loading dose cohort. And what we saw is excellent PK from the single ascending dose, where you had lovely dose proportionality, beautiful dose proportionality. We have a long half-life, 2 to 2.5 days, so already we're thinking of doing 2 things, dosing once a day, and already we're thinking with a 2 to 2.5 day half-life, we'll need a loading dose, and I'll show you that data in a moment. This is the multiple ascending dose for the IV, again, beautiful linearity. And the PK is also very, very tight between the subjects, so it's not like my old drug, voriconazole, which has a wide inter-subject variation. This is very, very, very tight, and so that will again help you and your colleagues treat these patients by having smooth and steady PK. The other thing to note here is the AUC levels that we're getting of around about 200, and this is above the target. Remember I said the target we need is double-digit AUC. Here we're getting triple-digit AUC, so we're already exceeding the AUCs that we think we need for the treatment of these clinical invasive fungal infections. This is our loading dose, obviously with a half-life of 2 to 2.5 days. If you want to reach steady state within 24 hours, which you want to if you're treating serious infections, you'll have to load up the patient, and we managed that and achieved that by giving 2 loading doses on the first day, 2 doses of 1,000 milligrams over 2-hour infusions. and then thereafter the maintenance dose was 600 milligrams once a day. And again, I draw your attention to the very nice AUCs here, above the double digit that we need for efficacy. And this is the copy-paste study. This is the oral study. Looks very similar to the IV study. And straight away, you'll see that the oral bioavailability is very high. It's above 90%. So the PK curves that you're going to see for oral are going to be very, very similar to the PK curves that you see for IV. And this means that you will be able to switch the patients with invasive fungal infections, switch from IV to oral, and you'll be able to switch with confidence. And again, one of my previous drugs, voriconazole, when we switched, there could be issues with lowering of the drug levels, and that's one of the reasons why you need therapeutic drug monitoring with some of the azoles like voriconazole. But I think with this compound, with a 90% bioavailability, you'll be able to switch with confidence. This is the food effect study. It's actually one of the slides that's better seen from the back of the audience because you will be unable to see that there are two curves. Professor Corneli at the front with his Hubble glasses will be able to just about discern that there are two different curves here. So they are overlapping curves, then there is no food effect. Here is the MAD for the oral, and again, the curves look very similar to the IV MAD curves. Draw your attention down to the AUCs here. So we're getting AUCs of over 300 when we're looking for AUCs, as I said, somewhere between 10 to 100, 10 to 80 for clinical efficacy. So in summary for these two studies, APX001, intravenous 1 hour infusion and oral tablets for 14 days was found to be safe and well tolerated. There was very little in the way of adverse event signals. Most of the adverse events were mild. If there were adverse events that were classed as moderate, they were for headache. Sometimes they received paracetamol for treatment. Nobody discontinued from the study due to any adverse events. And indeed, the Safety Review Committee could have dose escalated further in the IV study, and they could have dose escalated further in the oral study. But because we actually were exceeding the target AUCs that we needed, we decided not to dose escalate, even though we could have. I've told you about the loading dose, and we've achieved that in 24 hours. The bioavailability is 90%, so that'll enable physicians to switch with confidence. The PK is linear dose proportional, low variability. The only drug that I've worked on prior that's been as beautiful as this has been fluconazole. That's another very, very well-behaved PK antifungal drug. Half-life is 2 days, no food effect, and we didn't find any clinically significant drug interactions, certainly no drug interactions that were like the azoles, which were classified as strong inhibitors. It is not a strong inhibitor of the CYP enzymes. A couple more slides, and more futuristic looking. So I've described an almost perfect antifungal drug, and indeed I personally was sort of hunting this drug for 4 years because we licensed it from Eisai, the Japanese company. So I was looking for this drug and other drugs like this for probably the last 10 years. So what are we going to do with this drug? It's got just about everything that the perfect antifungal drug could have. Where do we go? So after much debate and talking to our colleagues and friends around the world, including Professor Corneli, we've decided to target the patients, first of all, with the highest unmet medical need. And this is our attempt to describe where the highest need is. And we think the highest needs are in these rare, high MIC pathogens, particularly those pathogens that can affect the brain, like mucorales. Also aspergillus, invasive aspergillus, and invasive candidiasis, particularly, as we heard from the last speaker, the candidiasis, candidemia that is resistant to standard care therapy. So we're thinking Candida glabrata, as well as Candida auris. And also prophylaxis, which is an interesting area, particularly for the patients who have acute lymphoblastic leukemia. where there's a problem with giving the azoles prophylaxis at full dose because of drug-drug interactions. Perhaps our drug here, with its favourable drug interactions, could have a play there. So this is a shout-out for our first clinical trial. This is going to be a small proof-of-concept clinical trial in Candidemia, where the PI believes that there is potential advantage of our drug APX001 over standard of care. For example, perhaps there is resistance at the hospital, or perhaps they are concerned about patients staying on IV therapy with the standard of care for a long time and want to switch with confidence early, or perhaps there are concerns if using an azole or a polyene about safety. This is a small study. I'm going to conduct it in 10 to 15 centres, primarily in the US and in the EU5, and that study should be kicking off first quarter of the next year. So in summary, this is a great time for antifungal drug development. There's, drug development pipeline was very, very quiet over the last 15 years, but I think you've heard from our colleague earlier with his excellent Synexis compound, our compounds, but there are others. They were mentioned on Oliver's list, F2G, etc. They have good new compounds coming forward as well as our compound, and I feel confident that a compound like ours, that's broad spectrum, IV and oral formulation, favourable drug interactions, so far been seen to be safe and well tolerated in healthy volunteers, has a good chance of at least advancing to the next stage. And one of these drugs in development will, I feel, in the next 5 to 10 years, be actually licensed and approved to treat your patients. And with that, I will close. Thank you.